Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a very interesting case of a patient who got referred to me by another audiologist. They suffered from severe otalgia. So otalgia is the medical name given to an earache, reduced hearing and pressure in their ears. The onset of their symptoms was a couple of months ago, if not slightly longer. And they went to their GP, who advised that they've got wax, and then they decided to go somewhere local to them to have it cleaned privately, to have the wax, what they believe to be wax, removed privately. And they went to an audiologist who actually watches my videos, and I know the audiologist is very keen to be notified by the patient as and when I upload this particular video, because they're very interested to see how I managed to remove this. Now, the patient over the course of 7 weeks went on I believe on a weekly basis to the audiologist, and because they found it so difficult to remove and it was really uncomfortable for the patient, and in between each of these 7 visits on a weekly basis, the patient was advised to use drops. I think the patient used all variety of drops. It was ear rolls with some olive oil spray, sodium bicarbonate drops, Otex. But in the end, they weren't able to remove this blockage, and the audiologist advised the patient to come visit myself. They follow my YouTube channel, and so the patient did their due diligence, attended. Now, the patient themselves is very sceptical that I'll be able to remove this in one visit, just because of how much difficulty the other audiologist found when they attempted to remove it. And despite knowing my credentials and knowing that obviously I do train people in this and I'm kind of renowned for what I do, but they were very sceptical. Now, the eardrum was actually partially visible. It was just the plug was still surrounding the canal wall, and although the symptoms are slightly improved, they're still experiencing earache, reduced hearing and a pressure feeling. Almost immediately, I diagnosed a patient with Keratosis Obturans. So this is not earwax. Keratosis Obturans, for those who have not watched my videos before, I have got a playlist on Keratosis Obturans. I'm going to add this to that playlist on my YouTube channel. So if you're not watching this on YouTube, you're watching it on a different platform. If you visit my YouTube channel, if you just type in on the search the Hair Clinic or the Wax Whisperer, you should come to my channel, and from there you can view all my videos, but also specifically on Keratosis Obturans. You can see what we're dealing with when we have patients who arrive with Keratosis Obturans. So what is Keratosis Obturans? The ear canal, just as I explained in my video yesterday, so the ear canal and the outer layer of the eardrum is composed of a layer of skin. This skin, as it dies, in the majority of people, it sheds and migrates sideways, almost like a conveyor belt out of the ear. So the ear self-cleansing, all the dead skin, as it dies, instead of just falling off in the ear canal and blocking one's ears, the ear has evolved over millennia to naturally shed and get rid of the skin that lines the ear canal once it's died and shedded, just by migrating sideways. As I explained, a bit like a conveyor belt, almost like a snake skin. And it comes out in little bits of skin that die and shed on the eardrum. It takes around 10 months on average for that to migrate out of the ear. However, in some people, this skin fails to migrate, and we get a collection of dead skin in the ear, and it forms into a plug. And this plug of dead skin can get bigger. Imagine a rubber ball in your ear, just expanding, to the point where it can actually start to widen and erode your ear canal. And that is not going to be a pleasant sensation. That can be really, really uncomfortable. And you get different grades of Keratosis Obturans. Grade 1, which is this mildest form, to grade 4, where the ear canal is so widened, where the ear canal, it's almost like you've had a mastoid cavity. So a mastoid cavity is a surgery that's performed whereby the bone behind your ear canal is drilled out, it widens it, and it almost enlarges the ear canal by 3 or 4 times. And that's the most severe case. And this plug of skin typically happens medially, so on the bony part nearer to the eardrum. And it can be one of the most difficult things to remove for a number of reasons. First of all, one of the main landmarks of keratosis obturans is pain. Patients attend with pain. A really uncomfortable sensation this is. Now, as an audiologist in the UK, we don't use any anaesthetic. So there's no lidocaine, so local anaesthetic, which is what ENT would be able to potentially use. Sometimes these procedures are actually performed under general anaesthetic because it can be that uncomfortable for the patient. And also, I don't actually have an assistant. So when I'm performing this, it's all by myself. So I don't have anyone stretching or expanding the ear canal. I'm in the ear with my instrument of choice in my dominant hand. So in my case, that's my right hand, and I'm holding the iClearScope endoscope, which is the endoscope that's inside the ear to visualise the ear canal at the same time of removing this blockage with my left hand. So we have to have the bilateral, we call bilateral cooperation or bilateral integration skills. So your right hand must be able to communicate with your left hand, and also both hands must be able to communicate with your brain. So it takes a while for people to develop the skill. Now, with this particular patient, they've also got a very narrow ear canal entrance, and there's quite a few cilia there, which wasn't actually causing that much of an issue. It may sometimes skew the view now and again for when you're viewing, but it wasn't affect me in terms of removal of this keratosis obturans. And again, it's just in my anecdotal experience, I tend find this condition more prevalent in the kind of the Far East. If you've got a Far East heritage, or you originate from the Far East, or you've got ancestry in the Far East, that's because a lot of people in the Far East have very dry ears. They don't have the gene that codes for an oily sweat to be secreted within the ear canal. And also I do find it in the Asian communities as well. And this patient is of Asian heritage. And so you can find keratosis obturans in the Caucasian or African communities as well. But it'd be interested to do a longitudinal study to see which heritage and cultural background or genes are most likely to code for this. Now, patient was in their 30s, and I suspect they've had this growing for a long, long time, but it's such a benign, slow-growing condition. They've never really become aware of it. So, just to recap what we've done in the last 4 or 5 minutes here, I've used a suction probe to try and lift this dead skin as much as away from the canal walls as possible. That's then allowing me now to use the forceps. I wasn't able to use the forceps originally because it would mean that the bottom jaw or the top jaw, depending upon which angle I'm going into the ear, would have to graze the canal wall to get behind this layer of really thick skin. It is really, really thick keratin that's coating the canal wall, and that would be really, really uncomfortable. And if you carry on watching, so obviously it's a long procedure, in the next couple of minutes or so, actually I've removed the blockage. So we can see the whole ear canal, see the whole eardrum. That's going to be done in the next couple of minutes. But there's an invisible layer of skin that's still coating the canal wall. And I spent the next 15, 20 minutes almost removing that, removed it completely, because I wanted to see what's underneath that layer of dead skin. Just in case we don't want to miss anything sinister or anything serious underneath that layer of skin, such as a canal cholesteatoma, for example. And near to the end, I actually do catch the patient. So whenever we train our earwax delegates, one of the things I always explain to the patients, or to our delegates, should I say, is be really, really careful when you're using any instrument, but particularly forceps and ear hooks and Jobson's horns deep in the ear, on the bony part, because the skin that lines the bony part of the ear canal is so thin, it's so delicate, it's less than 0.1 millimeters in thickness. You can imagine that. So it's not 1 millimeter thick, it's 1/10 of a millimeter thick, and probably less than that. And there's no fatty tissue or cartilage underneath that. So, and that skin is directly on the bone. There's nothing, as I said, in between buffering it. And with those instruments, because they're sharper instruments, if you catch that, it can not only be uncomfortable for the patient, but it can cause a bit of bleeding or bruising. And in fact, you will see it with the forceps, nearer to the end of the video actually, so we're still away from it. As I was going in with the forceps and trying to grasp some dead skin, the tip of the forceps is a bit pointed, it's a bit sharp, and I actually do slightly catch the patient's anterior canal wall near the eardrum on the left-hand side of the ear. And there was a bit of bleeding there, but the patient themselves didn't actually notice it, thankfully. But we showed them obviously what happened, just advised them to avoid any water. And by the end of the procedure, it clotted over by itself and it had healed and it was fine. It wasn't going to cause any problem. So this is this remaining crusted, hardened layer of dead keratin that I'm just trying to prise out from the ear canal. And it's a bit more tricky because the entrance of this patient's ear was a bit, so the lateral part, the outer third, was actually quite narrow. So here's the patient's ear canal. So the blockage is gone. We can see the eardrum, all that occluding dead keratin, that keratosis obturans has been removed. You can see patches, but there's a bit of skin to the left of the eardrum where I'm going now. Now, again, if this was my clear wax delegates, say, look, just leave this, don't worry too much about it. But I just wanted to, as a preventative measure now, because this is going to be a chronic problem for the patient, they are going to have to come regularly to have this removed. And whilst the patient was there, I mean, they've had 7 weeks of this in their ear prior to coming to me, and I wanted just to make sure I'm very meticulous and get all of this skin, or as much as I can, as safely as possible, whilst they were here today. And they did travel a long way as well, which actually shouldn't make a difference. It doesn't matter, irrespective of how far a patient travels to see me. We give the same treatment to everyone and under the right clinical circumstances. So, this keratin I wanted to remove off the eardrum because I just wanted to make sure they don't have a cholesteatoma forming. So sometimes the eardrum can be sucked in at the top. They can have a retraction pocket. And dead skin, now this patient's got a dead skin condition. Dead skin can collect in that pocket and form into a skin plug that grows into the middle ear and upwards towards the brain even. And it can get infected and it can be almost life-threatening that. It can cause meningitis, a brain abscess, it can erode all the ossicles, it can erode the facial nerves, it can get Bell's palsy. It can also erode and cause disease of the organ of balance. So just wanted to clear that top part of the eardrum just to make sure there's no retraction pocket, which there's not. So this is just some skin on the roof of the ear canal and also to the anterior portion, so to the left. And again, to the naked eye, you'd be quite surprised to see how thick this layer of skin is. It wasn't really visible. And you can, again, all the way around on the right-hand side is a layer of dead skin. Again, back at the roof of the ear canal. Again, I do encourage you to kind of stay right to the end or fast forward to the end if you don't want to see all this skin peeling. Because the final 10-20 seconds, you'll get a real good video image of the patient's ear anatomy. And you'll see all the bumps and all the craters, all the trenches, all the abnormalities of the ear canal, which you can probably get a gist of here. But once I peel all this skin that's coating it, it's a lot more apparent. So this skin, what's the best way to describe the consistency? It's in some ways hardened, but it's also very adhesive and thick and almost sticky in a way. It's got a lot of kinetic, that's the word I was looking for, kinetic energy. So you're really, really peeling it away. You can see I'm here, I'm up the base of the ear canal, and underneath here, you'll see a big crater once I remove this. This is where the keratosis obturans plug has widened and expanded and eroded the canal wall. And the best way to describe it is when you're lifting it off the canal wall, you're having to put so much pressure and have so much strength in your arm to lift and really peel it away. It's almost like a trapdoor that just wants to slam back down. That skin just wants to come back down again. And it's not a thin piece of skin that's just flopping around. It's really got a lot of strength to it and it just wants to go back to its original position. So we have to apply a lot of force in the opposite direction to peel it away. I wanted to avoid any drops if at all possible. I don't think I actually using the drops, partly because the patient's been using the drops for the last 7 weeks. Also, I don't know what's behind and underneath this thick layer of skin that's coating the canal wall. As I said, you could also be a canal cholesteatoma. Sometimes when you get a widening of the ear canal like this, that skin, as I said, normally it would migrate, it forms into, it kind of embeds itself into the ear, an opening within the ear canal, and it can disease that part of the ear canal. And again, this canal cholesteatoma is very rare, but it can start chewing away the flesh, the bone of the ear canal, and it can go towards the jaw. It can spread around the ear, the temporal bone. And again, it can be life-threatening. So we just want to, and if there is anything like that underneath the skin, I want to obviously avoid any drops in there because it could exacerbate their symptoms. But sometimes you've got to balance it, and if it's really hard to remove, we do use a bit of, I'd rather use a bit of drops if necessary, just to remove the skin to see what's underneath. So in a minute, I think I'm going to peel this away and you'll see the widening of the ear canal, which will give you more of an appreciation of the widening, should I say, because you can probably already see it. It's a little trench here. And this bit here, it's really hardened. I'm really pulling it away, lifting it off. It's almost like a thick glue underneath. So these adhesions, so the adhesion is when the skin is stuck to the canal wall. We call that an adhesion. And as you're pulling it away, it's almost like the skin is stuck on with a super glue. And it doesn't want to allow you to peel it. I think I'm not too far away of removing this. And we're just going to be careful that the tip of this suction probe doesn't poke into the bony part, because it's got a sharp ridge, and it can, again, that will be really, really uncomfortable for the patient. And you can probably see how much force I'm putting there. I'm just lifting it away. So, as I mentioned, we actually finished the patient's symptoms improved after about 8 or 9 minutes into the procedure. I got the blockage out. Ear canal was fully visible. Pain had gone, the pressure feeling had gone. What I'm doing now is a lot more preventative work, and I wouldn't have done this in my early days because it would just be a bit too tricky for me to do. I'm happy to admit that. This just comes with experience and just the know-how. You kind of understand the process, you understand what's required, if it's possible or not. Now you can see that widening there. You can see it's a bit red. That's a bit of blistering. That's where the skin was really, really stuck to the bony part of the ear canal. As we move it away, fortunately, it doesn't look like there's any kind of fully kind of diseased area there. There's no underlying infection. There's no discharge there, no wet dampness there, which is really good to see. And we're just reverting to the forceps, and we're just gonna. Forceps are really tricky using it in this particular patient because of the entrance of the ear was quite a bit of a narrow, but we still managed to get it in. We're using the micro forceps, got a 3mm jaw end, and I've got a grip, and I'm just trying to peel it at the same time, up and down. And we wouldn't be able to do that initially because we had to lift the skin off the canal wall so we can get the jaw underneath. Similarly here, there's nothing for me to grab onto with the forceps, so we're doing some proprietary work here. We're using the suction probe, just trying to lift this up. And you can probably notice the difference now. So you can see on the right-hand side, there's a layer of dead keratin there, and you can see the fresh layer of skin beside it. But when I first removed that plug, that wasn't really visible to the naked eye. It's almost camouflaged. And it's only now that I'm peeling away a lot of the skin, you can appreciate the undercoat, if you like, of the next layer of skin that's growing. Again, we do manage in the end to remove all this. So just going back in with the fine end suction probe. Just gently taking that. This is where the ear canal's really widened. There's a large cavity on the posterior side, so the back part of the ear canal. That's where this Keratosis obturans has really done its menace, if you like. It's widened, expanded, and it's eroded the back part of the ear canal more so than the front part. I think I'm going to go back in with the forceps now. And again, we're just going to be careful with the tip of it. And it's not yet, we're not far away, but you do see that I do catch it at the front part of the ear canal in a moment. So there's very little space to work with. If I widen those forceps any more than I am, because they're not fully widened, the top jaw will hit the front part of the ear canal, the back jaw will hit the back part of the ear canal, And if I go any further, the tip can poke into the eardrum, so be really, really careful. So I think for this bit, I'm going to go back in with the suction probe and peel it off. You see there's a little crater here as well as the inferior recess. There's a trench there caused by this Keratosis obturans. We call that the annulus region. So for the audiologist watching, this region here is the annulus region. And quite often you can get a canal cholesteatoma forming in this part of the ear canal near to the eardrum. And you can see there's gentle wriggle movements I'm using with the suction probe just to kind of detach the skin. You can see you've got this layer of skin on the anterior canal wall. And again, it's really strongly adhered. It's like a strong glue. And we have to work against it. So this bit I'm peeling backwards. Again, we want to avoid making contact with the bony part of the ear canal because that will be uncomfortable. And this is all in the bony part of the ear canal that we're working on. So just behind these hairs, so to the front part of the hairs, that's the cartilaginous portion, and anything beyond the hairs, in this particular case, is the bony part of the ear. And again, I'm just lifting this off the canal wall, and I think this is the moment in a minute I'm going to use the forceps. And I think this is the part where I do slightly catch the canal wall. So we're all fallible, we're all human. And it's just, you'll sit in a moment. There we are. I just catch it, the tip of it. Now the patient didn't flinch, didn't feel a thing. You see, we're still in the ear. Patient was fine, was blissfully unaware, but you can see I've just caught this delicate skin. It looks a bit worse than it actually is here, because it's just a little graze. But because it's directly on the bone, the skin's really, really thin. You can get a lot of bleeding there initially. And it's already inside the clot. It sounds a bit odd, but this bit of bleeding here actually helped to remove this piece of skin because it just softened it a bit. So without using any drops, it was almost like a natural lubricant, and it helped to peel the skin away from the anterior recess. And in a minute, you'll see me actually remove the clotting. So it clots so quickly. And that, I go back in and I actually remove the clot, and it just subsided almost immediately. So I've decided to leave that area for a moment whilst the clotting occurs. There's still a bit of skin here, you can see on the back part of the ear canal. So again, I'm just trying to peel this away. And I am going to return to that bit, so you will see that again in a moment. You'll understand what I mean by the clotting that I removed. Again, we're going to be ever so careful for reasons you've just seen. And I hope that's a good illustration. I often mention it in my videos that we need to be really, really careful. I'm always trying to be as careful as possible, but especially with the mechanical instruments. So when I say mechanical instruments, I mean the ear hook, Jobson horn, and forceps, because they're much more likely to graze and catch the bony part of the ear canal. And that's quite often, despite some of the comments that I read, I try and avoid it wherever possible. Now, sometimes it's not possible. We have to, if there's a clinical benefit, it's a risk-benefit ratio. Whenever you're doing procedures, if I've got a patient who's come in and there's only a teeny bit of wax, and they're saying that they can't hear and it's causing extreme pain, I know it's not the wax. So by performing a procedure, sometimes you can cause injury inadvertently. So I don't go on straight away to other assessments to see what is causing their blockage. Have they got acute otitis media? Have they got otitis externa? Have they got blocked eustachian tube? And if there's another valid cause for their earache, at least leave that bit of wax if it's non-occluding and it's not significant, because you only want to perform procedures where there's a clinical need. Now, in this case, because of the Keratosis obturans, they've had this blockage for such a long time, and it's already, the next layer of the Keratosis obturans is already forming. So whilst the patient's here, we're going to start with a clean slate. We're going to remove all this dead skin, if possible. And it'll just hopefully prolong his next visit, which I've advised him to come in the next year and sooner if they have any symptoms developing. So this is now on the cartilaginous portion. We can put a bit of pressure. So here on the cartilaginous portion, the skin's a lot thicker. It's about 1 millimetre thickness. Cartilage is a lot more flexible. It's not as rigid as the bone. The bone is completely rigid. And we can put a bit more pressure. But now the skin is now gone over the boundary onto the bony part of the ear canal, so we have to be really careful once more. So I think I'm going to go back for that clotting. Let's just see. So you can see it's not profusely bleeding at all. It's almost stopped itself almost immediately. And again, it's just on the anterior canal wall near the entrance. There's some skin here, and I'm peeling backwards here to detach it from the canal. Again, there's a bit of skin there, just to the left. Again, I'm just peeling backwards. And this is where the clotting is, you'll see. When I remove it, it comes out in a lump. There we are. And that bleeding is completely stopped. You can see the ear canal. So if you kind of rewind to the video after 8 or 9 minutes when I removed that blockage, I think it was around 9 or 10 minutes actually, and see it now, there's a complete distinct appearance. This is the whole ear canal, all the skin's been removed. We can see the ear for exactly what it is. There's nothing hidden away anymore. Everything's been exposed. You can see that massive crater mid-canal, and look to the right-hand side, it really widens. Just there to the bottom, you can see the crater, this extremely large widening, all these irregularities of the ear canal, all the bumps and trenches, which is going to make it hard for the skin to migrate now in the future. And that is now permanent, those erosions. They're not going to, very likely, just kind of get some more bony growth in those little holes and trenches to fill itself up. In the extreme cases, they can undergo a meatoplasty, where an ENT surgeon will try to kind of get rid of those bumps and fill it in, if anything. So yeah, it just helps with the skin migration again. But I hope you enjoyed that video, guys, and it was interesting. Take care, speak soon, and I shall upload some more videos during the week. Bye.